Good evening, everyone. It's my pleasure to welcome you all. Very good evening. And I would like to introduce our coordinators for this webinar. Rahul Sen is presently working as Chief Clinical Embryologist at Nilkant Fertility, Jaipur, Rajasthan, Executive Member of Academy of Clinical Embryologists, India, Executive Member ISAR, invited faculty for MIT University for ART Fellowship Program by Indian Fertility Society, and he has 13 years of experience in ART lab, published many national, international, published papers in international and national journals, and reviewer for Journal of Reproductive Healthcare and Medicine. He is a member of many societies, ISAR, IFS, ACE, and ISHRE. Our next coordinator is Dr. Sanketh Tomal Satya. He is a senior clinical embryologist at Shema IVF Fertility and Reproductive Medicine Center. It's has so many credits to his merit. He is the ISHRE certified clinical embryologist and on editorial board of General JBRA Assisted Reproduction, Reviewer General JBRA Reproduction, PLOS 1, JHRS, JRHM, and OGS. He authored few publications and to his credits author and co-author of 3 book chapters. Principal investigator for several projects at Shema Medical College. Is a member of ACE and ISHRE and Indian Science Congress. Is a regular faculty in various national conferences and delivered invited talk, lectures, and conducted workshops in field of infertility. Our next coordinator is Dr. Paresh Makwana. Is presently working as Chief Embryologist, Center Head at Wings Group of Hospital, Ahmedabad, Gujarat, India, and other associated centers of Wings. His key area of interest is experts in embryo biopsy, blastocyst biopsy in more than 4,500 embryos till now, oocytes and blastocyst vitrification, in vitro maturation of oocytes, and he is one of a Yuva team leader of IERA, Executive Committee member of ACE India, Life member for IFS, Treasurer in Indian Fertility Society Gujarat chapter, Lifetime member of Fertility Preservation Society India, the member of American Society of Reproductive Medicine. He is on editorial board in Journal of MSP publication, served as freelance embryologist in India and West Africa, and he has trained many national and international embryologists. So, I welcome all, and now I hand over to Dr. Sanketh for further proceedings.
Thank you so much, Charu sir, for that kind introduction. So, very good evening to all and warm welcome to today's webinar. So, I will be introducing, just a second, yeah. I'll be introducing the moderators for today's panel. Dr. Ved Prakash. Sir is MSc PhD and Lab Director at Southern Fertility and IVF. Sir, is my screen visible?
The screen is not visible.
Not visible.
Yeah, now it's visible.
Yeah. So sir is Lab Director at Southern Fertility and IVF at Delhi NCR. He is trained in IVF and ICSI from Andrology and IVF Lab at KK Women's Children's Hospital, Singapore. And he has done advanced IVF and ICSI and embryo biopsy training at VU Brussels from Belgium. And is president of AC India, Academy of Clinical Embryologists India, and a founder of International Human Embryology Research Academy, that is IHERA, and faculty and fellowship in ART, Amity University in Noida, and visiting faculty at MSc in ART, Mysore University. And his area of interest remains in vivo fertilization of blastocyst formation and innovation in embryo culture system. Welcome, sir. So next moderator is Dr. Akash Agarwal. So he is MBBS ST certified clinical embryologist and is working as a scientific director at Hegde Fertility, Hyderabad. He is alumnus of Osmania Medical College, practicing male infertility and embryology since 2011, and topper at ST Clinical Embryology Vienna 2019, and actively involved in academics and has co-authored a book chapter. He is active member of national and international fertility organizations like ISHRE, ISR, and IFS, and A's, and participated in multiple national conferences as a faculty and conducted multiple workshops. His keen interest is in male infertility treatment with surgical literate sperms. Welcome, Dr. Akash. So, over to moderators.
Start sharing the screen.
Yes.
Paresh is going to introduce that.
I would like to request Dr. Paresh to introduce the panelists.
Good evening, everyone. We have actually expert panelists with us. We have Dr. Sunil Jindal, andrologist, laparoscopy surgeon, and scientific director of Jindal Hospital and Fertility Institute. Welcome, sir. We have Dr. Raghavendra. He's a gold medalist in MCH urology, consultant macrosurgical uroenterologist, AIG Hospitals, Gachibowli, visiting consultant for Fertility Center, Hyderabad, andrology laboratory training. He is American Center for Reproductive Medicine, microsurgical training, Will Cornell Medical College. Delivered lectures in andrology at national and international scientific. Yeah, welcome, Dr. Raghavendra, sir. Now I would like to introduce Sanjay Yatnale. He is a good friend of mine. He did MSc Biotech from CCRG, and he is working as a senior embryologist in Pune. He has 14 years of rich experience in the field of embryology and got training for PGD biopsy from Dr. Alpesh Doshi at Aspire, Mysore. He has taken a hands-on training in ovarian tissue cryoablation organized by Asian Society for Fertility Preservation at Delhi. He has authored a chapter in textbook and active member of the National Fertility Organization ISAR IFS, and he's involved in various academic and training programs and conducted many IUI/IVF workshops. Welcome, Dr. Sanjay Yatnale. We have one more panelist, Dr. Hetal Shukla. He is a laboratory officer from October 1996 to January 2009 in production of frozen semen for AI and embryo transfer technology at IVF OPU in cattle and buffalo. He is a reproduction biologist from 2009 to 2015 and multiplication of the Arabian endangered national animal of an ART including SCNT. Just a minute. Yeah, he is working as a chief embryologist from 9th July 2015 to at present, and he is a managing embryology lab structure training of new Androtech, IUI workshop, and other in-house workshop to train update the Androtechs. Welcome, Dr. Hetal Shukla.
Thank you, Dr. Paresh, for that lovely introduction. I, Dr. Akash Agarwal and Dr. Ved Prakash sir, on behalf of IHRA, we invite you all for what we hope to be a very wonderful lecture for the next 1.5 hour of panel discussion on a very apt topic, which is semen analysis. Something very basic. Whenever we speak of male infertility, what we think of is the sperm. The moment we see the male infertility, we think of the sperm, whose sole purpose we think is delivering of the DNA safely to the female counterpart, which is the oocyte, ideally without damage. And of course, this is the most of the major part, excluding the microRNA and other things. And helping us in this has been the WHO manual, the 2010, the 5th edition, which was a very wonderful book, and which is remains a wonderful book, I would say. There has been a new edition, the WHO 2021, the 6th edition. There are minor changes in it, but both these books follow basically the evidence-based medicine, and they determine the semen parameters based on the fertility and subfertility. So we'll be looking into what the basic semen analysis consists of, how it helps, what is important, and probably what is not in the next 1.5 hour and so. And we'll be looking at the clinical aspects as well as the lab aspects. So I welcome all my dear panelists. We have a wonderful panel over here, quite experienced, and straight away we'll be starting with the next first topic. Over to you, sir.
So thank you, dear Akash, and I welcome again all the panelists who are here, and I know these all are the experts in the field, that clinical as well as embryological part. So as Dr. Akash said, this is a very basic thing, but we have to take care about that semen analysis as well, because without semen analysis you can't proceed further in IVF and how to manage your cycle. So first question to Dr. Sunil Jindal and Raghavendra, when do you want to advise a semen analysis test, and what is the role in male infertility?
See, one thing is very clear, that you would like to advise a semen analysis whenever the wife comes, I mean, with the wife, the husband should come. And whenever they have fertility, the two should.
So your voice is not
Your
audible.
voice.
Can you hear it
Yes.
now?
No,
Yes,
yeah,
sir.
yeah.
Yes, sir.
Repeat, sir. You have to repeat, sir.
Yeah. So when a couple comes to you to have a baby, it's not only the woman, it is the couple which comes to you. And whenever the wife comes, then the husband also needs to give a semen analysis. You may say that, well, 1 year of having stayed together and not having a baby is, as per WHO, the time when you should give a semen sample. But if you look at it in a different fashion, if a woman is more than 35 years of age and she's already spent about 6 months trying to have a baby, it probably becomes a time when then needs to be looked into, then to wait for a year and increase the time further. And that is the time when the husband.
Sir, your voice again break.
The problem with your voice.
Yeah, can you hear me now?
Yeah, sir.
Yes, sir.
Yeah, one sec, I'll just correct it. Now you'll hear me well.
Now it's clear, sir. Yes, sir.
Yeah. I have 3 mics with me and 2 of them are giving a problem. They're changing each other. So now I just have 1 mic with me. I have realized कि मतलब जैसे पत्नी एक ही होनी चाहिए, मैं बताऊं नहीं तो कंफ्यूजन मच जाता है. ये माइक्रोफोन भी की कहानी ऐसी लग रही है. चलिए. So now let's go on to that. So in case the age of the woman is more than 35, and what we normally say is if you're more than 35, then you should wait for 6 months and come over to get investigated. If it is so, then the man also should get his semen analysis done at the time when 6 months have passed post 35, or otherwise after 1 year of having tried together. However, if you have an idea that this man probably has had a varicocele, or this man has had a low sperm count, which had been tested before his marriage for any other reason, then these are men which need a semen analysis as soon as possible after marriage.
Dr. Raghavendra?
Yes, in addition to Dr. Jindal sir's answer, so whenever patients have undergone archaeopexy for undescended testes, so these are the patients where we need not wait for 1 year and extra year. So we can go ahead with an early examination. This is one. And some other patients where we come across, in addition to proper male evaluation, where they are coming in premarital status, questioning their capability of offspring. So that is one condition where they are coming up with a request for semen test. It the patient request we are doing. That is another condition where patients with chemotherapy going ahead with chemotherapy, those are the conditions where we do semen analysis and we'll test it, and if it is good we'll go ahead with cryopreservation. These are additional things which are not in routine but are special situations where we can go ahead with a routine basic semen analysis.
Thank you. Thank you. Akash, can you?
Yes, sir. So, as has been rightly said by both our eminent panelists, we see in terms of infertility, as has been outlined by Jindal sir, and as has been outlined by Dr. Raghavendra sir, we see some cases where might be not for infertility, and other than that also previously we can get it done. And it's quite a burden, and as used to be the case, the males still remain the neglected partner when it comes to ART treatment. Though they are equally responsible, still I would say they have a happy escape in their terms. Dr. Raghavendra, I would like to ask, like, whenever a patient comes to you for a semen analysis, so do you give any advice, or the common pattern would be most of the ART specialists, they'll say ki husband, get a semen analysis done. Or do you advise anything to them when they before you ask them?
In my clinical practice, for any patients before offering a semen test, so we'll make sure that there is proper abstinence, minimum 2 to 7 days as per WHO, but I prefer it is 2 to 3 days. So for all the patients, that is one thing. I'll ask them to go ahead with a proper natural way of masturbation if they are capable of doing that masturbation. That is one thing, and they should avoid any lubricants before giving this semen test. For unfortunate things, if they are not able to give sample close to the laboratory in the hospital setting, so I can ask them to give the sample at home, but they should reach the hospital within 1 hour or maybe 30 minutes earlier, keeping the sample close to the body temperature, so to avoid fluctuations because of temperature as well as pH fluctuations. These are the instructions. And if unfortunate thing, still there is a difficulty for some patients where they can ejaculate the sample only during coitus interruptus situations. If that is the case, we'll ask them to have a proper sperm friendly condom, so that they can give the sample within 1 hour. But all those things you should label it, the what is the way we are taking the sample, and also tell them to collect the sample completely. So initial portion which is sperm rich, they should not miss that sample. So complete collection is very very important. So some patients, if I think that they are anxious to give, some difficulty, some situational and ejaculations is there, for those patients beforehand I give some instruction with some PDE5 inhibitors along with some small anxiolytic. These are all the precautions I'll take before offering a semen test to any couple, with written as well as spoken instructions to the couple, especially to the male partner.
Yes, sir. So, Sunil, sir, you want to add anything to it, sir?
Yeah, I just feel everything has been said so beautifully by Dr. Raghavendra. But the only thing which I normally would do is, if the patient is coming for some procedure, then I always tell the patients to have a good bath with soap and water before they come. I mean, these are the instructions before IVF, ICSI, and even if they're coming for a IUI. And normally I would ask these people to wash their penis well with soap, clean it with water, or wash it with Savlon and saline well, so that there may be no contamination from outside and the prepuce, which may go into the collection. The second thing, I always give instructions, like in fact my team always gives instructions, that you open the container before and keep it when you start masturbating. A lot of these people, while masturbating and they're about to ejaculate, they start opening the container and they make a whole mess out of it because the container does not open and ejaculation doesn't stop. It's a crazy thing. So they need to open the container and keep it there. And apart from that, see, what I've done is we label it before and we ask them to read the label before. If there's anything wrong, it should be corrected. And then, of course, the room which has the semen collection should have a bell. All he should do is he should press the bell. It should not happen that he should keep and then go out to tell people. So it's a very, very simple procedure. But yes, cleaning is important. And if anything gets spilled out, please do not place it back.
Yes, it is rightly said by Dr. Sunil Jindal. Sometimes it happened that patient start ejaculation and forget to open the bottle, and that time that spillage happened, and he is not able to collect all the sample. This is very point to be noted. Yeah. Next.
We have seen so many many common times, especially during IVF, where we have a pre-analysis done and the count and volume is something, and we get something altogether different on the day of IVF, and the patients are so shy to tell even, they are so shy that they have spilled it. It's a kind of stigma, taboo kind of thing, ki kaisa batlayenge. And it is these instructions at this time that help them. And we make it a point that you ask for spillage compulsorily, irrespective of the patient's volume. Because like sir had said, it could be the sperm rich fraction, which is initial part and which could have been spilled. So though it looks a very simple thing, you can see it's a list of instructions. I wouldn't say very few. And this has to be followed routinely, and importance is there. Yes, sir.
In fact, Dr. Akash, I have them printed in the semen collection room.
Yes,
I have that whole print over there. And when the patient goes, the embryologist normally would go in and tell him, these are the instructions he speaks. Then he shows them to him and they say, please follow them again. So it becomes very simple. And हम सोचते हैं आदमी बड़ा बहादुर आदमी होता है, बड़ा डरपोक सा आदमी होता है, बहुत शर्मीला सा होता है आदमी. Just look at a man when he goes to give the semen sample and the container in his hand. I mean, it's not the way we normally think it is. Like you were just saying.
It's against the normal perception, right, sir? So now we'll be moving a bit away from the clinical side to the lab side. So I would ask Mr. Sanjay, once you get a semen sample, what are the care and precautions you take the moment a sample lands up at your lab?
Yeah, as we have already discussed, it should be handled as a biohazard sample. Okay, so it should be taken with the wearing gloves. And when you collect the sample, as we have discussed, we should ask the patient whether it is collected properly, completely, or not. Sometimes, patient, as we know, spill outside the container, and the proper information and labeling is done, and then putting the sample in proper like in laminar flow, maintaining the temperature between 20 to 37 degrees, like room temperature to 37 degrees is important, so that it can, and as soon as, means within a 1 hour sample should be analyzed. That is the thing.
Dr. Hital?
So do you keep it at room temperature or at 37 degrees centigrade in your lab? What do you follow usually?
Yeah, we keep it at room temperature.
Room temperature.
But we generally analyze, on XC machine with a 37-degree temperature. Yeah.
Dr. Hetan,
Okay.
would you like to add anything, and what temperature do you follow in your lab?
Usually when semen sample is delivered into the laboratory, if just by apparent look, if we find semen volume is low, then definitely first question will be whether is there any semen loss or not during the collection, and we make a proper note of it, so that it can help whether it was due to the spillage or not. Then sample container would be brought to the workstation under the laminar airflow in a waiting area where for liquefaction, and there usually we keep it at room temperature. So our workstation, we have a provision 37 degrees centigrade, half of the workstation, and half of the normal room temperature also. So the container which requires 37 degrees centigrade for the liquefaction, maybe at faster pace, then it will be placed on that also.
So, as has been outlined by our panelists, it is important that we follow uniform thing, whatever we do, whether we do at 20 degrees at room temperature, say 24, 25, or at 37 degrees centigrade, it has to be uniformly put. And especially more so 37 degrees is required for liquefaction because it's an enzymatic process. And enzymes, as we know, works best at 37 degrees centigrade. And as has been said by Mr. Sanjay earlier, that you have to complete most of your semen analysis within an hour. So the moment it lands up, there are first 5 things within the first 5 minutes. You check any spillage, low volume, look for the labeling, everything, and then wait for the liquefaction, and post that we'll see what is to be done for the main examination procedure and the post-examination procedure. So great, sir. If you can.
So next question to Dr. Hetal Shukla and Sanjay Yatnale. Parameters which you would look for in a semen before starting a microscopic analysis.
So in the beginning, I would add in my previous reply one more very important thing which is very important from the laboratory point of view, and that is, patient's identification. Patient many times may play some, it happens. He instead of him, somebody else is coming. So patient's identification is very, very, very important by asking photo ID and register, making a note of it in semen acknowledgement register. So that is really very, very important thing which we need to take care from the laboratory point of view, because if patient is aware his sample is not good, he may send somebody else. This can happen in any case. So this one thing,
it can happen. Though.
Yeah.
Yeah.
That's
So,
a very practical point where especially we have seen patients with azoospermia. Sorry, please continue.
yes. And then once the sample is given as before we start microscopic analysis, macroscopically, of course, yes, the sample volume, starting from volume, appearance, whether it does it have, because many times couple goes to the collection room, and if sample comes with blood in the semen sample, we don't know what kind of blood it is, and when we ask the patient, they may tell yes, because of the sample is collected with intercourse. Then this happens many times. This happens. So if blood appearance is hemetic, then it is very important to find out what was the reason. So it may help, it may take appearance if it is found, and if it is reported, it can also help to the doctor also, then what was the problem. So appearance and presence of extracellular material, if any, that also can be noticed and recorded.
That will
And
be microscope.
no, sometimes, body hair and some extra
Okay.
material, many times
Foreign
uh,
body type kind of thing.
it comes. So these things are really important to be noted.
We practice actually directly. One is physical examination, another is microscopic examination. Physical examination, we directly go with it's a volume. What is the volume? Then collection site inside or outside the lab, that we notice. Then another collection method, whether it is a masturbation or by manipulation, that definitely we record. And then the viscosity, that we check for these things. I think these are major 4 parameters we look before the microscopic examination. And the appearance,
How
color.
much
Yeah.
time do you
Why
start
do you
for this checking for this microscopy and other parameters once you have landed a sample? What is the time? Do you give any standard time as such in your lab
For liquefaction or
before going for the liquefaction and viscosity? Do you give any
yeah,
standard time?
20 minutes. Actually, we check it for viscosity. After minimum 20 minutes we wait. Then we, if suppose the most of the samples liquefy by 20 to 30 minutes. After that, suppose still it is not liquefied, then we wait for a maximum 1 hour. So then we manually liquefy by passing through the syringe, and then we check for the analysis. Yeah, actually.
So do you prefer any other method, or do you prefer the manual liquefaction? Which method do you do commonly?
I prefer manual liquefaction. That we can add some 1:1 flushing or this thing semen wash media. Then we have to pass through the 22 gauge needle by aspirating with a 5 cc syringe or something. So it easily gets liquefied. And if it is for
22
some
a little smaller.
22 gauge,
22
22. I prefer 22 gauge. Yeah. And for if you are doing semen washing, then if you go with the directly density gradient, then you need not to liquefy. You will directly get sperm separated. That.
But don't you think that if you don't liquefy the sample in density gradient, so that sample, that one thread like thing will appear in that in the that preparation pellet also from upper side
No, sir.
to lower side. Generally,
in pellet awareness.
Yeah, it is actually. I don't know how.
Maybe it's with the rare samples. Yeah. Okay.
Yeah.
It can
Sometimes it
happen.
happens that it is very difficult to separate out the liquid, that viscous sample.
Your opinion, Dr. Hital, about this?
Yeah.
We have two different opinions. So, what is your opinion about it?
See, normal liquefaction, normally liquefied sample, it's okay, fine, easy to handle, fine.
Yeah.
Whenever it is a viscous or hyper viscous, see, till 30 minutes, if it is not liquefying, it is viscous. After 30 minutes, if it takes 5-10 minutes more, then we declare it as a hyper viscous. And if it is a hyper viscous, then as my other panelist has said, we can pass it through syringe and needle. 18 gauge needle is preferred by us. If we can make it blunt, it is fine. And then if that is not helping in few passage, then maybe we can add some culture media to the sample and then give again few passages, and then it will. Of course, there are commercially available enzymes which we are not using, but there are enzymes available which we can use for liquefaction. We are not using it, of course, but it can be used. And I believe that yes, it is very important to liquefy the sample as much as possible when it is hyperviscous. Even in density gradient also, if oligo kind of sample is there, the post-wash yield in density gradient may be affected just because of the viscosity. and maybe the concentration and motility may give a false reading also, because it will be seminal fluid will have no proper distribution of the spermatozoa just because of the hyperviscous nature of the semen.
Yeah, there'll be inhomogeneous of this would be there. I would like to say that most of the cases, as has been told, it just by the manual liquefaction itself, but there can be just any one odd case where it even does not liquefy even after 1 hour, and you pass it through 18 gauge needle, you add 1:1, 1:2, 1:3, whatever you add. It just doesn't happen. So I've seen very few cases, might be 2 or 3 cases till now, but they do happen, and they were facing just infertility because of this reason. That could be one of the causes for infertility, because if the sperm does not liquefy, it can't come out of it, and the necessary capacitation and other things would not happen over there. So liquefaction is very important for us to proceed in terms of your semen analysis, uniformity of it. And as the panel is concerned with that, that's a quite important thing. Otherwise, it will be inhomogeneous, as well as for the sperm preparation, as has been highlighted by some, and might be sometimes if we are doing ICSI, if it doesn't liquefy also and you do, probably might help. So could be a thing which you don't know. And then there would be
Dr. Sunil Jinder over here.
Yes.
Sir, can you tell us about that? If viscosity is high, what can be the reason for that?
There are a lot of reasons for viscosity. It's interesting to see that a lot of people with these infections have a higher viscosity. I mean, normally the most common cause for a viscosity in the semen would be the infection. And a few people, otherwise also, if you take a very long history, you will realize that people with seminal vesiculitis, people with epididymitis past tend to have these viscous samples. It could be one of the reasons, but in a lot of patients, you just don't know why it is viscous.
So
anything can be done, sir, clinically
infection.
So
if it is, Akash, if it is viscous because of that inflammation or infection, so we can go for culture also.
Yes,
I think starting this.
Why not go for a culture? In fact, I always tell, we are very, very conservative towards culture. While if you have cleaned the penis well with soap and water and you're sure there is no contamination, there is no harm in getting a culture done. Believe me, I mean, people even say that, well, in case leukocytospermia is there, you can wait for, but you get a culture done in case you find so. And it's a very simple test. I mean, it doesn't cost anything much.
Yes, Akash, please.
Yes. So anything other thing can be done for increased liquefaction and viscosity from the clinical and other like lab and can be done, but anything can be done. Dr. Raghavendra?
From the first laboratory point of view, because I took my semen analysis training in Cleveland Clinic, so where the proper protocol is, they'll wait for 15 to 30 minutes. If it is not happening, they'll try 1 or 2 times. If it is not happening, they'll for another 15 minutes and then go ahead with chymotrypsin. They are using routinely that chymotrypsin, so that it immediately liquefies and it does not waste our time in assessing the basic semen analysis. Further, we can proceed faster, but cost is a factor, so we have to take into considerations. And clinical point of view, as sir rightly said, in majority of the cases, either delayed liquefaction or hyperviscous samples, most commonly it is an infection in our setting. So regarding that semen culture, I have reservations. So I routinely don't order semen cultures unless until patient is clinically symptomatic. So he is having some post-ejaculatory discomfort, some perineal pain or penile pain, or if the patient is having some burning while passing urine. These are the symptoms which I take into consideration on history-wise. On examination-wise, if patient is having testicular or epididymal tenderness, or there is irregular epididymis is there, where I suspect some spermatic or thickening is there, these are the suggestions, clinical clues for us, probability of an accessory gland infection, current or past infections. If these are the cases are there, then I'll also look at semen test, basic semen test. If it is showing leukocytospermia, provided they have done properly the ENDS test and labeled it as a proper leukocytospermia, then I'll order semen culture, because in majority of the patients, either because of improperly done semen culture or it is a properly done, but still it is a positive culture where we tend to treat these patients unnecessarily with antibiotics. I have reservations in semen culture. Selectively, I order semen culture in all infertile male patients.
Yes, Sunil.
One thing is very clear, that the indications for semen culture, as Dr. Raghavendra said, are true. That is what you always need to get done. But there is something for us to understand as people who also do IVF-ICSI. And you know what is there to understand? For us, there is to understand that the patient has no symptomatology of infection. We have examined him, and 90% of the times in most of the IVF clinics, they don't have somebody to even examine the man. I'll be very honest with you. At least Dr. Raghavendra can examine, I can examine. These are the places where a semen culture before an IVF is mandatory. One. Number two, before you going in for a big procedure for any patient, where the man has to give just one thing, his sample, it might as well undergo a culture. And this is very important because, you know, any semen culture positive, and if during IVF you have a contamination of the tissue culture, my goodness, everything has gone. And all that you need is a simple semen test. So apart from what Dr. Raghavendra has said, the indication would be, if we are undergoing, if the patient is going to undergo any procedure with the wife, like an IVF or an ICSI, it is a very good and positive idea for the patient to undergo a semen culture.
Right. So I would like to ask.
Agree with Dr. Jindal sir's advice, but for all the patients, probably you have to give proper instructions for semen culture. So as WHO manual also clearly says, patient has to void urine and he should dry it with a disposable, and again he has to wash. Those instructions are very, very important. Otherwise, they'll get false positive cultures. So I absolutely agree, Dr. with Jindal sir, with practical point of view. When they are going ahead with a big procedure, it is better to have a baseline culture.
I would like to ask our embryologists, like, do they ask for a regular semen culture before they do IVF? Because
actually, as Dr. Jindal said, we do mandatory semen culture prior to going for IVF in the batch, and we do mandatory, it's compulsory semen freezing, because we know sometimes it's difficult for patient to produce a sample on the same day. So as a backup, when we take the sample on the same day, we send sample for a culture, then we treat accordingly. And very rarely we get the culture positive, but as the doctor said, we are going for a big procedure and just for a simple test, and it hardly cost $400-500, and then with a simple antibiotic treatment can be done, and nobody would like to, you know, disturb the whole procedure. Take a chance with that.
Dr. Hitan?
I think it is indication based only.
Not in all cases of conventional IVF?
No, not.
They are not doing a conventional
IVF. We are not.
Okay. So as has been highlighted, it's semen culture is a very simple test which can be done, and the panelists, most of them are of the opinion, especially before IVF or ICSI, it's better to get it done. So that is what consensus we can get probably over here. And after that, it's indication based or it's a personal choice how to go ahead with that. And I think we missed out a bit on pH. So Dr. Sanjay, if you can carry forward, like when would you like to, like how do you do the pH? Like do you use a litmus paper or do you graduate it? Like normal says 7.2 to 8, but do you give a value for it, or it's alkaline and that's sufficient?
Yeah, actually we just we do pH paper this thing test, and not routinely, I would say. We just go with the microscopic and that parameters only. Yeah.
Okay, so not on a regular basis pH.
Not on regular basis.
You don't check whether it's alkaline or acidic.
Yeah, no.
Mr. Hetan, yours? No.
Yes, we also, we are not doing, only when we have a doubt that there is a probability of semen mixing with urine or something, then only we will check with strip test, pH strip test. That's all. We don't do it routinely.
Okay, but we might be missing some cases of dysfunction in case because alkalinity is missing. I would say that pH meter, like rightly said, we don't go in for a value on a regular basis, but like again, you could be missing, we could be missing a few of the tests, few of the indications, especially in low volume. Yes, obviously the indication is there to do, because we, in such cases, we are obviously missing the case where it could be obstructive, non-obstructive. It gives a lots of idea of pH. And increased volume in infections and pH. I would like to ask, how many times have you seen a change in pH in your experience? Both of you might be thousands of samples. So how many times have you actually seen the pH is not alkaline?
It's
No, not once. Okay, so anytime you have seen it acidic or neutral. So
I think if it is value based assessment, then it is better to have a proper assessment on this, because this strip test will not give very fair idea about this.
Okay, so in that case, we are missing quite a few things. Yeah. Because what I would say is that with a litmus paper based, like has been rightly said, rarely we see acidic reaction. Even in patients who have culture positive ones, we rarely see a case where it could be orange or red colored. I have never seen. I've seen only probably one or two cases where it was a case of severe obstructive azoospermia where the volume was less than 0.5 ml. So what my experience is probably we see towards the neutral end. Yes, towards the neutral end, I have seen a few cases where it was there. So we do as a routine in our lab. We find that it's helpful as an adjunct. It's a choice, and WHO says it's better to get it done. So
Akash,
yeah, Dr.
Can I add one thing, practical thing, which when I was in Miami with Ranjit Ramaswamy,
yes,
as a clinician, he examined in the OPD where the Canadian couple is there. It is a CBAVD case. We ordered semen test. Laboratory technician has done semen analysis, has given azoospermia. So then we asked, pH is alkaline. Just immediately asked, have you done the pH test? He said, just I have written like that only.
Yes.
Again, he retested, it is acidic. In almost in 90 to 95% of the cases, if it is because of an obstructive azoospermia where seminal vesicle hypoplasia is there, so definitely it will be an acidic, because in almost all the cases where I see CBAVD, it is acidic pH. We are doing it routinely. Probably we are not looking at thoroughly.
Yes.
Because whenever low volume azoospermia, immediately look at pH.
Yes, so that's a very good indication of from the lab, and that would be helpful clinically, that you are showing them that it could be an obstructive cause, low volume, low pH, obstructive azoospermia. That's the one which comes.
They are not doing this pH actually.
Yeah.
We are doing only by using that litmus paper.
Yeah, we are doing only with litmus papers, right, sir? But even that helps.
No, but litmus paper, if you put it against the meter, you get
you get quite a good indication whether it's alkaline or not. Alkaline or not, we do get an indication. And the only thing is we should be doing it.
Let me be honest, I don't think you need anything more than a litmus paper at least.
Yes. So usually what we do is, even for litmus paper, you get that from companies, which is you get a bundle full, and you just what we do is after you have taken the sample, what we do is we just break it and pour it in, and you see the color change immediately. That's what we do. That's what we do. Okay, so we'll move on to the next question. So what are the semen parameters we would look for in the microscopy and their importance in the lab procedures? Mr. Hetal, if you can take this one.
Yes, of course. The three fundamental semen parameters: sperm concentration, sperm motility, and sperm morphology. Again, a very important one. So these are very important, and all three parameters have their very important values for whether it is. See, there are three options: ART treatments, IUI, IVF, or ICSI. And for all these three options, IUI, IVF, for both of these, the samples value will definitely help to decide the course of treatment and any further things. So, sperm concentration, of course, but sperm morphology, I would say that it is very important, very subjective also, and that's where laboratories has to find some way how it can be made objective, because concentration and motility, of course, with very intensive training, one can definitely make very objective, but morphology, it has lot of subjectivity in it.
Right. Like count is quite objective, has been said, and motility can be made to a degree of objectiveness, and morphology is quite variable, and like has been said, it depends on the training and everything. And how do you, what is the volume you usually do? Like this is like you usually take 10 microliters and you make a wet slide for it just to check for that. And your concentration lower limits are somewhere in the 15 million earlier. And importance of mixing and liquefaction would come over here, because once it is changed, if it's not properly mixed, and what they usually say is to always mix it immediately before you take it. Mix it at least 5 to 7 times before you're going to pick a droplet of it. Otherwise, there would be variable number in it. The nomenclatures, what we have seen, which has been told already. Do you do regularly with the Mecklers, or do you follow the slide method for this? For the sperm count?
For sperm count, Meckler chamber.
Uniformly across. Mr. Sanjay?
Yes.
Yeah, we go with the analysis compulsory with the Meckler chamber.
Do you use the wet mount preparation, what we call it as? Do you use it? Wet mount preparation, where you do it directly on a slide?
Yeah, we do. Yeah, it's
you use it
just for a cross initially for cross checking in that way. So, and for morphology checking, it is, you know, with the Meckler chamber, it's difficult to observe with a 40x. So if you have to, for that, you better go with the wet mount.
Right. So wet mount can provide you with a very good, Mr. Yeah, please.
For sperm motility assessment, many times I have seen that many people simultaneously, along with sperm concentration, they score motility also with Meckler chamber. I would say it will be always better to assess motility on a wet mount on a slide, glass slide, because you know it is in a percentage. It is always represented in percentage, and Meckler chamber, of course, you know, it is the center of the entire Meckler lead, and most of the motile spermatozoa tends to be in the center of this smear. And if you are doing it on the glass slide wet mount preparation, so from the center of the slide to the edge of the slide, if you count the number of motile, immotile sperms and everything, then motility assessment will be close to the accurate.
Yeah, we need to take everything into consideration, and like has been said, it has to be with a wet mount, because your Mecklers is only 10 microns depth, and that is not the right depth for assessing the motility. And if you do the assessment in the initial part itself, once you allow the drifting, what we call as to stop within half to 1 minute, so probably it would be quite uniform across the entire slide, entire cover slip, I would say. So that's where the variability would tend to be decreased. So we have seen the sperm count, the motility we have seen, and obviously the important part would be the progressively motile, rapidly progressively motile, which has been once again brought into WHO 6th edition. And we know about the progressive and non-progressive motility, because they are the ones based on the motile count, total motile sperm count, how you would actually decide for the level of treatment. And sperm morphology, do you follow the Tyredberg criteria, strict criteria for 4%?
Yes, we do follow for that 4%. Yeah,
4%. And you can get quite a few other things as well, TZI, teratozoospermic index as well from that. We'll not go in details of this morphology, because that's a topic for altogether different day, entire lecture in itself. And I would like to now ask Dr. Jindal and Dr. Raghavendra, like, what is the importance of oligospermia? Like, how do you convey to the patient what its importance would be when a report turns out to be abnormal?
Oligospermia would be a lower sperm count.
Right, sir.
And a lower sperm count than 15 million. So the question is, does the low count below 15 million, actually, first of all, our understanding is, does it mean it is the cutoff of normal and abnormal? So it actually is not the cutoff of normal and abnormal. It is just the 5th percentile of the calculation which has been done. So keeping this in mind, we need to keep into our mind the motility which is there. And in fact, the most important parameter after the count is going to be the motility, especially the progressive motility. So we would like to know if the progressive motility and the total motile count is good or not. First thing. Morphology is a secondary issue. And if the motility is fine, then of course the viability is going to be fine. So once we have known that the patient is oligospermic, depending on the progressive motility, there's a judgment of how you need to convey it to the patient. So conveying to the patient is very important, because for a man to be conveyed that your sperm count is low is the biggest bad news you can give to him, because it actually shatters the whole human being as a man, because somehow they correlate the sperm count also with manhood. So it becomes very important. So these are the people who normally would be told that here's your sperm count. The sperm count appears to be less than normal. Your motility is excess, which actually after calculating it appears that you need to be investigated further. This is something which needs to be told to them. Now, similarly, if it comes to asthenospermia or teratospermia, asthenospermia more importantly, if there is asthenospermia, then of course, along with this, we would like to get a second sample done. The second sample, if confirms, we'd like to examine the patient. Mainly, most of the things which would be affecting are going to be any signs of infection, any place for a varicocele, any place for any kind of infection or varicocele, or any testicular or epididymal finding clinically. So you just need to correlate these and tell the patient that you are oligospermic, let us investigate you further, and then go ahead and treat them. But there is one very important thing. Every patient has one question. The first question which our Indian patient asks is, ये ठीक तो हो जाएगा जी? दवाई से ये ठीक तो हो जाएगा जी? First question. ये दवाई से ठीक तो हो जाएगा? He wants to listen yes. And I'm just saying a very practical kind of a thing. He wants to listen yes.
Right.
But you should never say yes. You should always say only one thing, which I do. I always tell them, let's see, कुछ में तो हो जाता है भाई. Bas. So this is something which gives them hope as well, because you need to give these people hope. Because otherwise what happens is they leave you and they go to the person जो गारंटी शुदा शुक्राणु बढ़ा रहा होता है. और वो जो गारंटी शुदा शुक्राणु बढ़ा रहा होता है ना, वो पैसे कमा रहा होता है. हमको पता नहीं क्या कर रहा होता है. But that's what happens. So this is the way I would normally, when it comes to talking to the patient, it would be there. But yes, you also need to ask these patients a few other things before collection. If they've had fever, any illness, any problem apart from that. And then, of course, you'll examine them to find out what the problem is, put them into investigations.
Dr. Raghavendra?
As has been said by you, sir.
Yeah, sir, covered almost. Sir, covered almost all the things. But I want to make sure that any abnormal count, motility, or morphology, I want to reassess with at least 1 month retesting. Just I want to make sure that it is not a natural variation of the couple for that person. That is one thing. And I'll also make sure that whether they have given proper sample and properly done, and also want to know the lab status. Whenever I see patients coming up from peripheries, if I do even for azoospermia patients, when I repeat that, still there will be 10 million, 15 million count will be there. So in the practical situations, these are all the things probably we need to take into consideration. Other than all the things are corrected, or we are making sure those things are not there. So as sir said, in majority of the patients it is idiopathic, or in other patients maybe it can be a examination finding, is it can be a varicocele, or it can be their occupational exposures. whenever they are working in a pharma industry with chemical exposures, and some patients with lead industries. So these things, for all the patients, we need to take into consideration of their occupation also. For some patients, I'll tell them probably if there is a chance, change your occupation. So these are the things we can tell them. And lifestyle modifications, anyway, everyone will tell, reduce obesity, all regular exercise, all those things probably. These are all the things will count for these all abnormalities. And also I'll tell all the patients, whenever these things are there, something is going wrong with the testis, with the spermatogenesis. It can be with some known reason, or it can be an unknown reason, or it can be a genetic reasons where we are not doing proper evaluations. But still there is a chance, even couple with less than 1 million can impregnate their partner, whereas a normal person cannot impregnate their partner, because we want to know the status of the female partner also. But still we can give them some hope and with some remedies.
Is there
It's not
any
an
situation in that there is one case I know that one patient came to in our NCR center. He gave sample over there. There was no sperm seen in that sample, and in his place there was very good count. Again, that person came to our that center. He gave sample. Again, there was no count, 0. He went his place. He gave sample over there. There was count normal. So he was very angry with him. So what could be the reason for that? This is very tricky questions. Actually, that patient came to me in my main lab, and when he came over there, and I gave him a very, I call him in the morning, early morning, and gave him a room, separate room, and he gave sample over there with his wife. And at that sample, when I checked that sample, it was absolutely normal. So what could be?
For these situations, probably the laboratory quality and assessment is very, very important. So there is one situation.
No, yeah.
Dr. Raghavendra, that person was trained by me, and he was actually, I think, more than 6 years experience. He was doing that andrology lab.
If those things are there, we should go to towards WHO manual, where there is a normal person can have almost close to 0 sperms, and at the same time he can have 300 to 400 millions at sometimes. We should tell them there is a seasonal variations or individual variations. So probably maybe in that stage we can repeat and we can reassess.
I think sometimes it is because of not proper collection, because of anxiety or different places. It happens with the patients. I have seen one patient, it was an infection, and for follow-up I checked the sample, it was 0. Then immediately I asked the patient to produce it, and there was sperms in that. So sometimes it's the accessory gland secretion only, so it's a 0.
That's what I mean.
So no, it happened.
I called him in the morning, early morning. There was nobody in that hospital, and gave him separate room. He able to produce sample, and it was absolutely normal.
Dr. Ved, it has happened with me. There was a patient who had to come for an ICSI. We got his sample done earlier, and the sample was extremely poor count, less than 5 million. And we planned an ICSI for him, and the day he had to give a sample, the sample came absolutely beautiful, full-blooded sperms. Crazy. So I had a very, very strong feeling that there is something wrong. So I told my staff, so I told the members in the team that you take another sample of his. And this time when he goes into the room to give a sample, please make sure of 2 things. And I told him suddenly. So there are 2 problems which happen. I'll share with you. One problem is somebody else has given a sample. And the other problem is he's carrying a sample in his pocket. There are two things which can happen. So I made sure that the moment he gave the second sample, which came as absolutely, the first sample which came absolutely normal, I said, don't tell him he has to give another sample. Just go and give him the container after labeling it and signing it, and tell him he needs to give another sample. And I would like him to change his clothes and go, I mean the gown, and then go for the sample. And believe me, the second sample also was teeming with beautiful sperms. So the truth remains, just like you had this issue, it again is the WHO story. And I think that's the only thing you can give as an explanation, because I really got afraid. See, somebody less than 5 million, 1 million, 2 million, or whatever it was, and he suddenly has 100 million sperms. And it's the same laboratory, my place, where everything, well, I think everything is done well. I realized, and there were about 3 samples of his less than 5 million. That it was 100 million. So I had to get it checked.
Yeah, for
Temporal
that, generally
variation.
we practice asking a patient whether when they are below the normal parameters, then we ask whether you were comfortable when we collected the sample, and it was normal like you generally when ejaculate it is same like that, or it is more thinner than the regularly you ejaculate. So we get the idea that because of anxiety sometimes patient is not comfortable and they just ejaculate, maxillary gland secretion, and so it gives, so confirming with another sample is always a better option.
It's a common complaint which patients have usually, that they say that at home the ejaculation is normal. I mean, that's quite common, and they don't know why the volume is less in the center.
Exactly.
Same thing.
And one thing I will add, please. One thing I will add, Dr. Akash.
Yes.
Just give me this 1 minute.
Sure.
I have realized that men who have their phone with material which can help them to give a semen sample. See, the days have gone when you had a television set placed in the semen collection room. Now, all these people, when you get a semen collection, have to be told beforehand that your phone should be in a situation that you should be comfortable to give a sample. And the interesting thing is what? Whenever the staff asks them, तुम्हारे phone में कुछ है क्या जिससे आप आराम से sample दे सकते हैं, तो सारे कहते हैं नहीं. फिर कहते हैं फिर वो लेके आइए, बोले कोई बात नहीं, काम चल जाएगा. I have realized that they may not have anything in their phone, but they are very good at streaming. So every person can stream something onto his phone, because of which this problem is not there. And whenever they are able to ejaculate with arousal, his sperm count is better. Just like
stimulation and arousal is very necessary, and in terms of proper collection as well.
If you permit me.
Yes, please, sir.
Yeah, see, I have as per my experience, I have noticed patients have 2 types of myths in their mind. One is, if they come with longer abstinence, their semen quality and quantity will be very good. And so this is also one thing. And sometimes what they report, they say, oh, since morning I have not taken any breakfast, nothing is there, so I will not be. So collection issue and all this, all anxiety and everything comes because of lot of myths in their mind. So counseling, proper counseling, and definitely proper counseling helps in getting semen sample as well as good quality normal semen sample.
Okay, so Britson, can you take forward the next questions?
So next question to again Dr. Hetal and Sanjay. What do you do when you do not see any sperm under the microscope?
Yeah, as we discussed earlier, we generally when there is no sperms, we centrifuge the semen sample with adding media and we check for the pellet. And if there are no sperms, then we report that it's a azoospermic sample and please correlate it with other clinical tests like blood tests, LH and FSH. And definitely we confirm the semen about azoospermic. We repeat test after 3-4 days or 1 week apart, and we ask the patient as we discussed that whether it was properly collected or not.
Do you actually scan the whole slide, the whole cover slip?
Yeah, I do. Actually,
because that's almost
yes. So azoospermic, we 3-4 drops we scan for complete this thing, and then we centrifuge it and we check the whole palette actually. Yeah.
Because that's almost 1200 fields if you can see by that. And,
but I think you get used to, even if there is a single sperm twitching, you get it. Yeah.
Right.
So,
yeah.
Yes. So whenever there is no sperm initially on the slide or in the macular chamber, then yes, we concentrate it by centrifugation, and then we will try to find it out. See, I have kept that 40 mm cover slip also. So 2-3 slides we will scan with that big cover slip, so that entire palate can be checked, and then we declare azoospermia. And we during this assessment, if whether we will, our effort will be whether ixiable, at least ixiable quality, number and quality, both forms are available or not, and accordingly it is reported.
Yeah, before voting, definitely we ask for one more collection on the same day. Whether we can ask if patient is comfortable, or we can ask, and then and then another thing is, then we ask for the physical examination by clinician about the testicular volume and all these things, and then rest of the things will be taken care. Like if you're planning for ultrasound of scrotum, or then trial test or something like that.
Usually what we do is, like, whenever we have a sample of azoospermia, like as I said, we always ask the patient whether the collection was complete and abstinence, and they were comfortable giving the sample. And plus we don't declare it, give a report straight away of azoospermia, because it can be devastating. Like has been said earlier, when you convey the report of oligospermia itself, it is a shock to quite a few patients. And when you say azoospermia, many of them might go into depression as well. So that's why you always ask for a repeat sample to be tested once again. WHO as well says that at least 1 week apart, and then only we issue a report of azoospermia, especially if it's the first time. If it's a repeat of it where we have a previous report, yes, you can go ahead and give it the azoospermia for that matter. And they say that if you are not able to, and if you're not able to see a sperm, these are the rough guidelines, like what would be the sperm. It's always better to say that you could not, any sperm could be visualized. It's better that you repeat the sample over there. And you should always be watchful about retrograde. That is one thing which we tend to miss. Retrograde ejaculation is one thing which you should always ask for, especially where they have dry orgasm or something, where patient will say that they did feel that something was different, like they could feel a fluid which was going backside or something, and patients give quite a good indication about it. Dr. Rajendra.
Yeah, so here we should also rule out is a pseudo ejaculate. So that is pseudo azoospermia, what we call. So some patients with ejaculated situational anejaculation, sometimes they'll give only urethral secretions instead of proper semen. So probably that is one condition where we should be careful. Is there any sample difficulty during sample collection? So probably that will add to the additional thing, in addition to rechecking the sample.
So, Dr. Raghavendra, how would you manage a male? You get a report which says there is zero motility. So, how would you manage him? It's a zero motility account, could be anything like 10 million or 20 million, even normal.
What we call it is an absolute asthenozoospermia. There is absolutely zero motility. It is a quite difficult situation for us as a clinicians. So probably in these situations, maybe the reason some ultrastructural defects, where dynein arms may be defect in immotile cilia syndrome. That is one condition, and other conditions like mitochondrial dysfunction. Some mitochondrial mutations may be there, but unfortunately we are not able to test those mitochondrial mutations in our clinical practice. That is another condition where we come across this absolute asthenozoospermia. These are the two rare conditions that lead to absolute asthenozoospermia. On top of that, practically if the person's using condoms which are latex condoms, that will give almost zero motility. If they are using any lubricants, so these are the things probably we should go back and ask them whether are they using these things. If nothing is there, so probably for absolute asthenozoospermia, there is no clinical remedies of little importance. We can try something, some antioxidant, something, but I don't think so. These patients will improve better with medications. This is a right away indication for ICSI after properly knowing that there is a viable sperm with a Haas test or any laser shot, or it can be you can go ahead with pentoxifillin or theophylline.
And probably somewhere infection would also play a role.
Yeah, if
very few patients with absolute asthenozoospermia with zero motility, so still it is a possible causative thing. Infection as also.
See, what I normally find is if there is a complete there is no motility at all. So the first thing which normally, as just Dr. Raghavendra has said, this is the truth that most of them would have a major problem. So the first thing which I would like to get done is a Haas test. I would know whether viability is there or not, vitality is there or not, first thing. So there are two kinds of divisions I would make. One in which vitality is there and the other in which vitality is not there. If vitality is not there, then of course it could be a genetic problem, be a mitochondrial problem. There's very little which any one of us can do about it. But if viability is there, then the only things which we probably can look into, which may be rare, would be genital infections, any kind of anti-sperm antibodies too, though it once again is very controversial. Any kind of, I like to ask him that has he abstained for a very long time? I mean, I will not say that it will give to absolute, but with a person with a low count, it will motility in these sperms. And well, this is what I'd like to do in these patients, examine them and see. I always do a culture. I always do a culture. Many people do not do it, but I always do a culture of a man who has immotile sperms to check if infection is there. And I'll give you, I'll also share something with you personally. And Dr. Raghavan, this is important. This is very interesting. I got this patient with complete immotile sperms, and he came to me with the idea that I'll be able to take some sperms out of his semen and do an ICSI. So he come to me from Kanpur. So I told him that, well, it's totally immotile, and even in Horse test, there is not a single sperm which is of any vitality of any use. So he says, there's something which you need to do for me. Something which you need to do for me. And I will only have my own baby. So I said, well, the option is that I look in your testes, if we could find some sperms which are viable, though once again, it will be a problem. Can you imagine what the gentleman said? Give me medicines. And I gave him antioxidants. Dr. Raghavendra, this is important because this is beautiful. So I gave him antioxidants for 4 months. And after that, we went ahead and did a horse test again. We found a couple of sperms, 3 or 4 sperms, which were viable. We planned, we did an ICSI for this man. We got embryos, good embryos, didn't get pregnant. That's a different thing. But ultimately, at the end of the day, probably taking out infection and giving antioxidants would give them a very small chance.
If I may add one line.
Yes, please.
When semen sample shows absolute asthenospermia, it will be always good to have immediately, with the shortest possible time, second subsequent sample on the same day. Many a times, not always, but many a times, second sample shows some or a very good motility on the same day. And this probably will help in further planning.
Yes.
Yeah, there is a recent review article by Cleveland people for these necrospermia and absolute asthenospermia. Shorter abstinence and frequent ejaculations may give some hope.
Yeah, right.
Yeah, short ejaculation, shorter abstinence, as has been said. Even some people tried for even DFI and even for ICSI, for lowering the DFI and ICSI. So it definitely will not do any harm, at least if you're going for an ART. And whether you can find any sperm which is live or not, that would be an important thing to see over there. And any views about absolute teratospermia? We have seen patients who have absolute teratospermia, so that would be, I mean, a very rare thing, but it does happen, right? So what do you do in such patients, treatment-wise, management-wise?
Absolute teratospermia, because of round spermatids, that is a globospermia. That is one condition where we cannot do anything. Straight away, we can tell them to go ahead with an ICSI without wasting much time. Clinically, we can advise, but very rarely we can see all these indications for absolute asthenospermia, maybe the reasons for absolute teratospermia. But as per morphologies contains too much of subjectivity will be there while examining also. So we have to take all those into consideration. I think clinically in these situations, we can try for infections and antioxidants and antibiotics and anti-inflammatory agents, and we can reassess if they are responding, that is fine. Otherwise, maybe majority in idiopathic state.
So it's mostly empirical treatment which we do, especially for cases of absolute astheno and teratospermia.
Yeah, empirical treatment, and just like Dr. Raghavendra said, just examine if there's a varicose, operate on it. That's it.
Right.
But
Okay.
as
So
per EAU guidelines, absolute teratospermia is a contraindication for varicocele repair.
But you know something interesting, I have realized one small thing. And what I've realized is that, and I'm saying this very, very practically.
Yes.
For a man who has all sperms which are abnormal, and he comes to you and says, what do I need? And you've given him antioxidants, you've given him antibiotics. There's very little which you can do. He has a varicocele. For teratozoospermia per se, not absolute, otherwise, varicocelectomy is a surgery. And Dr. Raghvendra, let me be honest with you, not many people even suggest varicocele surgery because nobody operates under a microscope.
Yeah.
And what happens is, every gynecologist says, iska koi fayda nahi hona.
Yes, sir.
And most of the surgeons whom they would go to, they normally would not like to use a microscope, or they don't use it, and that's okay. So by operating by them, it doesn't give them a good chance. And what happens is that varicocele surgery per se has become not the standard procedure in the minds of people as well.
Yes, sir. That is practically, you were saying right, sir. When I started my practice, gynecologists used to say, no, it is not useful. I told them, just give me some time. If it is useful, I'll do under microscope. Then you refer patients. Now they are referring patients.
So
Definitely, there is under microscope, there is a difference, huge difference.
Huge difference. And believe me, we do IVF ICSI at our center. We get so many patients of varicocele. And there's so many times it comes to us with low sperm counts that let us not operate on these varicoceles. We just need to take a sperm and do it. And the moment you do a varicocelectomy for these patients of low sperm count with teratozoospermia or whatever, the quality of the sperm improves, the DNA fragmentation improves, the quality of fertilization, and I would say the take-home baby rate too increases. There is no doubt about it.
it has been proven with papers that it is the most common treatable cause of male infertility would be varicocele surgery.
Yes.
And almost 40 to 50% of them spontaneously conceive, irrespective of the count. Just you do a varicocele surgery, it should be utilized, but with judiciously in selected patients. Then yes, it does work, and with the right approach of the surgical technique.
Correct.
And you'll take the next question.
Yeah. So now we are moving to immunological disorders kind of thing. The role of anti-sperm antibodies, and what is the significance in male infertility?
Wow, what a beautiful question to be asked. Because, you know, it will always remain in controversy.
Yeah.
When I started my work, at that time, anti-sperm antibody was the most important thing, because in case there was any kind of motility problem, immotile sperms, anti-sperm antibodies were done. It took a long time to tell people that anti-sperm antibodies should be done where? So getting the anti-sperm antibodies done in the blood, in the cervical mucus, in the sperm heads, everything went one. Now today agglutination takes place, we know anti-sperm antibodies are present. We also know that a lot of people give steroids to these patients, they don't really help. So the question of, and most importantly, please, how many people and how many laboratories are able to do anti-sperm antibodies properly? That's a very big question. In fact, when I started and I used to get anti-sperm antibodies done at a particular laboratory, I one day thought, let me go and see how they are doing it. Because at that time, they would, and I realized that I didn't really understand what they were doing. For the prime reason that there are very few laboratories which actually are able to do that. Well, today, I would say agglutination if present, anti-sperm antibodies are done, and immunobead test is normally done. But I really do not know how useful they would be, because today, despite doing an IUI, if they don't get pregnant, ICSI always is present for anti-sperm antibodies. So it always will remain controversial. I think so.
Dr. Raghvendra?
Coming to anti-sperm antibodies, I said it is a controversial thing, but to be precise and practical, so honestly, none of the laboratories are doing this anti-sperm antibody test, whether it is a MOR test or immunobead test, according to WHO, on the sperm surface. We are interested in sperm surface antibodies, not in the blood. So that is one thing, practical difficulty. And clinically, if it is useful, whenever there is a history of agglutination, high grade of agglutination is there, there is a probability of some anti-sperm antibodies, or in case of post-vasectomy recanalization patients, or some trauma is there in their childhood, those other patients, or some other infections in their childhood. These are the patients where probability of anti-sperm antibodies will be high. So given the clinical limitations of these testings, because when I was in Cleveland Clinic, I used to do these tests. There is a separate thing where we need to add where donor sperms will be there. We have to cross check, their beads will be attached to the sperms. We have to count them properly. So, but that situation, I don't think so. Very few laboratories are doing. Recently, I reviewed one article on this anti-sperm antibodies. So probably it is an underutilized test. Probably it may have role in future with accumulated evidence. As sir said, steroids have limited role, but unfortunately the study with steroids in these patients is very less, because these are not proven patients with immunological infertility with proven anti-sperm antibodies in their sperms. Probably still this is an area where there is a scope of lot of research. We need to wait for the science to answer these things.
Any patients who was helped with this test and with steroids, either of you, who actually was helped with the steroids or any other treatment?
In very few patients I have seen where one patient with almost azoospermia, clinically I have seen where there is a irregular epididymis and bulky epididymis and bulky spermatic cord. I thought there is a probability of chronic infection. I have given them steroids for 6 weeks along with calcium and pantoprazole combination. After 6 weeks, there is a 3 million sperm count is there. Later on, he has gone ahead with IVF ICSI. There is a natural conception for that guy. But these are sporadic things where we cannot generalize for everyone.
That's
Dr. Hetal, would you like to add something? If there is sperm agglutination in the sample, will it will change your sperm preparation method or something else? Would you like to do something else if there is high agglutination?
Whenever there is a very high agglutination, just like liquefaction means viscosity breakage, we can add some culture and allow some swim up or something, or maybe density gradient with diluted semen sample may help in getting the semen sample from agglutinated sperms.
Sanjay?
Sir, I don't think there will be that much agglutination that it will be difficult to process the sample. It's rarely in some areas, like if we screen for the 10 fields, then 1 or 2 areas we can see, and that too when they are near to apoptosis, mostly we have seen the agglutination. And if we technically check about, definitely both methods are okay, whether it is a swim up or a density gradient. Yeah, it should not be a problem. Yeah.
Even for agglutination, to be precise, it is head-to-head agglutination is more important than other types of agglutinations.
Right.
Which will come in the way.
And what we have to probably differentiate from the important thing would be aggregation, where it is a random and not site-specific one, and which is the one which is more commonly encountered. And when we are just beginning in the field, we see aggregation and we are like, we have found a case of agglutination, which most of the time turns out to be wrong. So we have seen very few cases of agglutination over here. And I think next question, we can probably skip this one because it is what we have already covered in our earlier discussion. If a patient is unable to do what is to be done. And so next question. Yeah. So do you test the semen for fructose regularly in the lab? Like, most of the places, like it has been said, for pH. So
no, we don't do it regularly.
You test for fructose. Okay.
Yeah, we don't check it regularly.
Okay. And Mr. Ethan, do you check for us?
No.
Azoospermic cases. Yeah.
We are not checking.
Okay. So what method do you use usually? Do you use a quantitative one or a qualitative one? If you see in azoospermia, which one would be using? Do you do it in-house or do you
we refer it to the we refer it to the lab and where the facility is available. Mostly in our facility, we get qualitative, means absent or present. That is the thing.
Absence or presence of it.
Yeah,
Mr. Ethel, what do you like in your lab?
No, we are not doing this.
Okay, for fructose, okay, this because there are some qualitative ones where you can just get the presence or absence of it, but not in terms of the quantitative, because that's a very difficult test to do. And
for quantitative,
for quantitative, we are also
you need that setup chemiluminescence and
So, do you see any difference if the quantitative one comes less, Dr. Raghvendra or Dr. Sunil, sir? Or any treatment you would advise? Say the fructose comes out low in a normal one, what would be it? And obviously, its importance in obstructive azoospermia we know, in azoospermia, sorry, as an obstructive case. But say in a non-obstructive one, that it comes out to be low or very low count one, people they come fructose as low. So, do we need to treat that as such per se? Is it important clinically?
So unfortunately, fructose we are doing routinely in our laboratory, but I'll tell them if you must do in all cases of azoospermia where centrifugal pellet is not showing any sperms. So document is pH and fructose for all azoospermia cases. It is a mandatory in our laboratory. So we are doing only qualitative, not quantitative. If acidic pH and fructose absence will give many clues to me. So there is a seminal vesicle hypoplasia. It can be a case of CBAVD. So these are the clinical clues and which will emphasize my clinical diagnosis of a CBAVD without doing an MRI or transrectal ultrasound. So simple basic semen analysis will emphasize clinical diagnosis. That is one thing, that possibility of an ejaculatory duct obstruction, some utricle cyst may be there by bilateral ejaculatory duct obstructions. Definitely it has got a clinical importance. So for all azoospermia cases, we do routinely this fructose test. We are doing this modified Selvinov's test because whenever these patients are with low volume ejaculate, it is very difficult to do these tests because they always say it is insufficient sample to do the test. For these patients where there is a 0.1 cc of Selvinov's reagent with 0.5 ml of semen is sufficient for doing this calorimetric test where there will be a different color so that they can identify. And coming to the quantitative assessment, probably clinically, it will give some clues. There is a possibility of it can be in a partial retrograde ejaculation or it can be a partial obstruction. But clinically, it gives some clues, but treatment-wise, I don't think so. It will change much on a clinical.
Much of a difference. Dr. Sunil, sir, you want to add anything to this?
Well, as far as fructose is concerned, hello?
Yes.
Hello?
Yes, sir. You're audible.
Yeah, as far as fructose is concerned, we normally get it done. What we get normally done is the qualitative. We don't get a quantitative done, which is normally done, and it's a resorcinol test. Actually, honestly speaking, you can't do it in the lab where sperms are being tested. So you have to have an outsource or a separate room where you can do this for that reason. And it can be done very clearly. So, but we normally do not do it in every patient. We would normally do it in only those patients where we feel it is needed. That's what we do.
Right.
And if we talk precisely about the quantitative fructose, that there is a little difference between when there is oligospermic or the normal sperm. Because sperm utilize the fructose as an energy source, there will be a little lower than the oligospermia. So if as we know, the cutoff is 1.3 like gram per liter, and if we consider the normal, which has a 1.5 or 6, then oligospermic we can expect something nearly 1.8 or something like that grams per liter. So a little bit higher, yeah. But then that's why if we have to say low means, then it should be the lower than the what is the acquired reference value. We can say it is, I think this time it says 1.3 gram per liter. Yeah.
Yeah, I think they quantitate more per ejaculate as such. So like has been said, what we can do is we can do a semi-quantitative or a qualitative one at the lab and then decide whether it's present or not. And if required, like we can outsource this for a quantitative to the outside. And we'll quickly move forward to the next few questions. And as time is short, we are actually overshooting it a bit. So quick question to Dr. Ethel, like how do you do Q and QC of semen analysis in your andrology lab? Like, do you do Q and QC? What precautions do you take in terms of inducting new persons in your andrology lab?
So we have a very structured training schedule where microscopic and macroscopic analysis and everything is. So we have reference slides for morphology, even images, because macular and motility and all, it is always with other colleagues and all, standardized. It is with like that. And for morphology, we have reference slides and Oligospermia sample slides and head, midpiece, and tail problem slides and all. Yeah. So we use these slides for training the new.
So how much training do you think it is required to become a endotech?
I would say depends, but 3 weeks is my structured training program. 3 weeks.
So 3 weeks would be sufficient for motility and count morphology as well.
Yes.
But that would be under supervision, or after 3 weeks
Under
or
supervision. At least first 2 weeks. First 2 weeks will be under supervision.
Okay. So what do you do when you see quite a few variability? You see start training someone new person, and the tendency is they give more towards the mean, and there'll be quite variable results, especially towards the extreme. What we have seen, especially when they start off and they go haywire. So
I think only way is to have a very good reference to the what we want to give them. That's all. I think.
So during the training, we need to have a very good reference slides for them.
Yes.
And one of the ways what I do is like, cross check, just have a look whether they are deviating too much or not.
Yes.
Minor deviations might be there, but just do a cross check, whatever slide they have prepared initially.
Exactly.
And as time goes, probably like I said, 2 weeks or 4 weeks later, we can give them independent charge once they are quite comfortable doing it.
So
and this is a slide which shows that this is a variability which is acceptable.
What I do is, every parameter and everything, at least 10 they have to observe. Then at least 20 they will be doing under supervision, and then independent but with cross checking. Like that
would be roughly 50 if you go that.
Then they will have to maintain the logbook also of everything.
Yeah.
So
that's a good point to maintain. Like, we should always, before you give them independent charge, and might be post them at a satellite center, especially if you have one. So it is always better to be sure before you give them independent charge. Quick views about extended semen analysis. Dr. Sunil sir, Dr. Raghavendra sir.
Coming to extended semen analysis, probably already most of the things are covered. These are anti-sperm antibody tests, DNA fragmentation, some genetic analysis, sperm aneuploidies, and even advanced towards an oxidative stress testing and morphological indexes. So these are in selective cases, not on a routine basis. We'll do. Maybe it is labeled on anti-sperm antibodies and all other tests, leukocytospermia test. So not on routine basis, in selective patients will do.
Okay, so your views on the new 6th edition has appeared. So does it make any difference in your practice if you have gone through from the previous edition, any major practice changing?
Let me be honest before answering this question, because I have not gone through the manual completely, just I have seen an overview. So where there are few changes, where coming to the motility, as you mentioned in the beginning of the lecture, we are going back to fast progressive, slow progressive, and immotile, that ABCD category, because where they are with role comes into picture, because always we want a fast runners to win the match. So definitely that category, probably it is more important, what I feel, because it was difficult with the previous one. That is one thing where they are precisely mentioning and with extended explanations for DNA fragmentation, those test methodologies where DFI testing for tunnel test, or it can be a halosperm test, or it can be a CSA. But unfortunately, still they are diplomatic. They are not labeling any threshold values, because they are saying just it is only to the laboratory where you need to standardize these cutoff values or thresholds in your laboratory, in your populations. That is one thing they are mentioning. And other thing, but only important thing is total count is more important than the sperm concentration. So then accurate estimation of volume is more important for this total sperm count, because it is the fertility potentiality of an individual where total count is there. There are n number of articles on total progressively motile sperm counts are more impressive, are more important for an IUI success rates. So these are few changes, and they have given extensive literature when compared to previous manual. So they have given little bit practical things also. And coming to the reference ranges, it is almost similar. Initially it was from 4 continents, some about 1900 people. Now they have included around 3000 people from some more areas, even China, some other areas are included in that. But doesn't change much. These are validating the previous 5th edition reference ranges. Other things probably they are mentioning about a role of anti-sperm antibodies, and highlighted the importance of sperm aneuploid in case of recurrent pregnancy losses. So I had to go through the complete manual to say precisely on each topic. Probably I would like to hear from other panelists on this.
It's quite extensive to go. Dr. Sunil sir, you're on mute. Sir.
It's very extensive, it's very thick, and it's very big. I personally have not gone through it, but the overview which I wanted to go through to just understand, I've realized that they've put in a lot of basic things for everybody to understand how the analysis needs to be done. They've given a little bit more importance to the functional tests and the extended tests. So they have divided it into basic, extended tests, which is useful. And probably they've made something which will, at a global level, make everything more easily comparable, doable, because they've put in a lot of checklists into this. So I have a feeling that way it will be nice that today Dr. Hetal, Dr. Ved, Dr. Akash, Dr. Sanjay, when they do, because of those checklists if complete, they would be able to have a comparison amongst each other. So I think that is one thing which would be very useful.
Dr. Hetal?
Yeah.
Dr. Hetal.
In the 6th edition, they have, I think, recommended use of decision limits to identify abnormal ejaculates. This is additional to the reference ranges. And in that, normal ranges, borderline ranges, and pathological ranges are defined for each of the parameter, which needs to be means I have to go through the values, what are they, but these are the addition to it, which is in an effort to differentiate fertile from infertile men. And motility grading system, they have gone back to the 4th edition, that 4 categories of rapid progressive, slow progressive, non-progressive, and immotile categorization. And DNA fragmentation and ROS testing as a extended semen analysis are being recommended. That's what at the moment I can comment upon.
Yeah, I personally feel that there is no definitely big difference between the reference values. This much variation we can see even in a person to person, like 0.1 ml or some 1 million or something like that. And I think it is not right to expect every time the different reference values, just because, like if you see other blood parameters, I think if it's a 1.5 lakh is a basic for platelet count, so it's same from the long time. So for every 10 years, how can we expect a different difference this thing value? Another thing is for extended examination, I personally feel Just because sperms or semen is easily available as a gamete, we consider comparative to the oocytes. We do experiment a lot, and there are whatever the procedure, those are invasive. Whether it is a DF or some other test to check its DNA status. Still, I hope there will be some technique which will be known in use and we can use that. Because end of the day, when we go for a ICSI, then you don't know what sperms you are choosing. We just treat, suppose if it's a DFI, we treat them with antioxidant, and then we consider it is improved. And then end of the day, which we choose, we are not sure whether what is the status of that sperm. Yeah.
Okay. So, Ved sir, your opinion on this?
Hello.
Yes. Okay, so as has been said by all our panelists, there's not a huge difference in this, and there's a quite a minimal variation, and rightly said by Mr. Sanjay that it just could be a normal change of drifting of the values which or observation made by the different persons who are doing it. But what it does is it does bring across uniformity across the different global regions, different person, different labs, and this is more of a reiteration that it is more, what the 5th edition has told was correct, where we were quite skeptical, like there's a huge drift in the values in terms of normal values, but this has reiterated that actually there's a drift, and what the 5th edition was saying as normal in terms of percentile, once again, not differentiating with respect to fertility status, but in terms of percentile, that's it's in the right direction that they are moving. And we have short of time, so we'll just take a quick yes or no for the next few questions. Role of DFI routinely or not routinely? All the panelists, yes, no, like
No.
no.
Not routinely.
No, no,
Not routinely.
not routinely, only indication, and
Okay.
cannot be outsourced. You need
Okay.
you need a frozen
In-house, yeah.
sample. Yeah, you need a frozen sample to be sent to a laboratory who can thaw it as well. So it cannot be outsourced. It needs to be either a frozen sample or a fresh sample.
Okay. So everyone doing in-house, so we take it that way.
Yeah, I'm doing in-house. Yeah,
Outsourcing.
Outsourcing. Okay. And the different methods, and what rightly said earlier, that they have very cleverly not given any reference values at all. For DFI, they have not given any reference range. They have just said in WHO you need to calculate your own for your tunnel. And
Dr. Akash, I think it's very important because they really cannot give it.
Yes. No, I'm not saying that it is a fault on their part. The problem is with the variability of the test.
Yes.
It's with the variability of the test which is done. And why I say cleverly, because it's not just going to the pressure and where they have to give a value exactly to everything. We tend to associate a number with everything. That's a human tendency. We tend to associate a number to everything.
Absolutely.
So the different methods, each one again individual choice. Tunnel and SCASA being the most common words. ROS, do you advise, again a quick yes or no? Do you do, like obviously in indicated cases, ROS would be advised by you?
Not routinely in selected cases.
Selected cases, okay.
Actually, not most of the labs are not doing this ROS. Actually.
Yeah, ROS is being done very,
it's not easily available.
Very rarely.
Yes. And there are quite
actually,
a few variability.
Studies say that if you should check within a 10 minutes, so it will be ideal ROS. With the time decreases the ROS level, so it's very difficult to manage that thing. And I think it's not that significant. Everyone feels so. It is very rarely we.
Probably for this test, we need to wait for future where there is a test, my access device in Cleveland Clinic, where they test redox potential, which is easy test, hardly 1 minute test. So probably we should wait for that. So it may be standardized in future.
I would like to ask this one question, like, high DFI or high low count, and might be ROS abnormal in case you are doing it. So after the most commonly used treatment is oral antioxidants for male fertility, and empirically as well. So do you repeat it? Do you advise the patient? Quite a few patients like it was abnormally and advised me for high DFI or high ROS. So do you actually repeat it after giving a course of say 2 months or 3 months?
Or how long you want to give that?
And how long do you want to give?
I normally give it for 3 months and I repeat it. And let me be honest with you, I'll just add, Dr. Raghavendra will add, of course. I'll tell you the antioxidant which people need most commonly is vitamin C, vitamin E. These two they need. And along with this, whatever cocktail is going given, it can be given. But yes, I personally repeat it. And I think it's important. I also look if there are any infections. I want to clear any infections. If the person has a varicocele, operable with all the indications, I would like to operate on this patient. And that's about all you can really do about it.
Yeah, considering 72 cycle, we do repeat after like 2.5 months or 3 months. Yeah, of the course.
So for almost all lectures, I'll tell it is an integrated approach where there is a proper evaluation from the female side, proper evaluation from the male side, correct the correctable things, and if you are not in a position to correct those things, refer them in time without wasting biological time. So probably we should give better results to the couple.
I think it's a very important thing which Dr. Raghavendra has said. Please refer them in proper time and don't change the biological clock and the timing of it. I think that's very important.
So last slides for the day. First one, we have already covered the one like in pre-pubers, pre-adolescent or adolescent ones going in for fertility preservation or something like that. Last one would be opinions about CASA and automated semen analysis from all the panelists. Sanjay, you can go first. Or sir, you can go first after.
Yeah,
please. Go ahead, Sanjay.
Please.
See, CASA I have used, but there are still consensus regarding the count this thing. So I personally feel that the manual method is much better than the automated one. Yeah,
it is.
We are doing. Yeah,
I mean, there is no confusion. It is just that you are able to get a system in which you have people who have 10 or 12 IVF centers. They want a standardization, so they would have CASA at every place. And instead of standardizing the laboratory personnel, if you want to standardize by the machine, you can do it. There are two things which probably I feel which are a problem. Number one is morphology. You cannot get a very good morphology with the CASA machine. And the second thing which I personally feel is that the motility may be a bit higher. These two things could be there. And apart from that, if you're able to standardize your procedure with the CASA machine at your place, you would definitely have to do with the CASA regular manual, I would not say checkups, but regular manual reportings so that you could standardize and get both the reports together. You cannot do that. You just do a CASA and do not do the manual part of it.
Using CASA, I have used it in veterinary side. Human side, I haven't used. But I would say in human laboratory, if CASA is to be used, then definitely I will be selective for the modules like morphology and DFI. See, morphology and DFI if done with sperm chromatin dispersion test, the halo measurement where medium halo and small halo may have some interchange. I mean, medium can go to small or small by new learned or inexperienced androtex. So in that, to bring that objectivity in morphology as well as in DFI like counting, probably CASA modules can help. Rest otherwise human, I mean microscopic examination is unavoidable in IVF laboratories or IVF ICSI laboratories. That's what I feel.
Coming to these automated semen analysis, we have done one study in almost 400 male infertile patients with two well-trained embryologists checking for semen analysis along with the machine. After 400 patients, there is not much difference in count and motility. And coming to the morphology, ultimately it is a man who has to choose those sperms. So these machines are not much useful. Because the preparation of the slide is very important for morphology. If they are not making the slide properly, definitely it will give wrong impression. So where the facilities are not available for trained specialists for doing manual things, probably we can take help of these machines. So some way the count and motility we can presume probably with eye precision, because they can pick up very fast. with high motility also, because I have done with calciumation in when I was in Cleveland Clinic as well as in my center also. So definitely they have a limited role, but ultimately it is a manual method. The man behind the machine is always important.
Always.
Right. As has been said, that CASA will serve as an adjunct to you, but it will not replace an andrology technician who is going to do the test. And end of day, they are not going to tell you which sperm is ICSIable or not when you're especially going for a case of ICSI. So CASA still stays to a large extent, especially the cost being prohibitive to a large extent, and in Indian scenario, it is very much applicable. And I think with that, we'll just have a conclusion of this. And it was really wonderful session. Thank you to all the panelists. And we have seen that semen analysis is the cornerstone for male infertility diagnosis, probably the first and many a times the only test which is ordered for a male infertility diagnosis. It is not limited to count, motility, and morphology. As you have seen that during the discussion, they probably form not even 20-25% of our time. There are so many more things to look into it. Your vitality, your pH, your volume, their liquefaction, there are many other things which you need to go in detail. And each and every aspect is important because that particular aspect could be the cause for infertility in that particular patient. And until it is resolved, you are not going to treat the patient properly. And your basic semen analysis is not complete. It's usually not like earlier times, and many a times you need to do advanced semen analysis where a patient is going to have probably a male factor is there, but his parameters are going to come normal. He's not going to have either oligoasteroma or teratospermia at all, and volume might be normal, and still it might be a male factor infertility. So in such patients, your extended semen analysis comes to your help, and DFI, ROS still to be taken up on a wide scale basis, but they have a role to play definitely. And though superficially it might appear to be a very simple test and which can be standardized, but it has its own set of complexities, and it is quite a complex test with quite a few variables to do. And this is where the WHO will help us, has helped us, and is helping us getting uniformity across the board. So thank you everyone from my end. Thank you for the lovely responses, and I really enjoyed the session and going to the varied responses and the clinical and the lab aspects of it.
Thank you so much. Thank you so much, everyone. Dr. Sunil Jindal, Dr. Raghavendra, Dr. Hetal, and Dr. Sanjay Shukla. Thank you so much. It was wonderful panel, and we learned a lot from you. Thank you. I hope, I am sure that all the delegates also learned so much thing from our experts. Thank you.
Thank you very much.
Thank you so much, Dr. Raghavendra sir, so much.
Thank you.
Dr. Hetal and Dr. Sanjay as well. It was really wonderful having those practical experiences as well.
Thank you.
Yeah.
Very much.
सुनील सर मैं बोलो बीच में कुछ
मैं तो देखो एक बात बताऊं आपको मुझे
क्या है सर, आपको सुनना हमेशा एक बहुत ही जॉयफुल एक्सपीरियंस होता है। मतलब मैंने इतने सालों में जब भी देखा है आपकी बात, मतलब कुछ लगता है, मतलब कि हाँ ठीक है, देयर इज समथिंग व्हिच वी कैन ऑलवेज। आपका प्रेजेंटेशन का स्टाइल मुझे थोड़ा सा यूनिक लगता है।
पता है आपको एक बात बताऊं चारू जी, जैसे अभी यहाँ मिले ना, आप मिले, वेद मिले, हमें राघवेंद्र मिले, आकाश जी मिले, हेतल जी को मैं जानता नहीं था, संजय मिले, हम सब मिले, तो मतलब मुझे इतनी खुशी होती है इस टाइम पर। ये जो जॉय होता है ना मेरा अपना, सिर्फ ये निकल के आता और कुछ भी नहीं है, आपको सच कह रहा हूँ।
होपफुली हम पे भी थोड़ा वो असर हो जाए सर, असर हो जाए।
यही मैं
सुनना चाहता हूँ आपका।
So happy, thank you so much, वेद जी, चारू जी, and I wish, देखिए मैं आपको बताऊं, अभी एक कॉन्फ्रेंस 2 दिन पहले हुई, वो डॉक्टर नरेंद्र मल्होत्रा ने की। The joy of going there and meeting everybody was so beautiful. पर सच बात कहूँ, ये एकेडमिक्स इस पे बेटर है। यहाँ पर बहुत सारे लोग मिलके सब सुन लेते हैं, पर जो मैं हमेशा कहता हूँ, किसी भी कॉन्फ्रेंस की जान उसकी शाम होती है। मतलब दिन की कॉन्फ्रेंस कभी याद नहीं रहती, सिर्फ शाम के मजे याद रहते हैं। तो वो अब शाम की मजे को शुरू हुए हैं। चारू जी, आप सबसे मुलाकात होगी, बड़ा अच्छा लगेगा।
चलिए सर, हम भी शाम के मजे एंजॉय करेंगे आपके साथ, वर्चुअली सही।
चलिए,
thank you so much, sir.
Thank you everyone.
Now thank you so much, Dr. Ved sir and Dr. Akash, and the panelists, Dr. Sunil sir and Dr. Raghavendra, Dr. Hetal and Dr. Sanjay. Now I would like to hand it over to Dr. Charu sir for vote of thanks.
Chalo, it is again, it's my pleasure to say thank you all of you. It's a wonderful presentation, wonderful discussion, and definitely it is beneficial for the viewers. And hope to do such kind of webinars in future also, as it allows us to do. Physical, though I suppose still it is in another 6 months we cannot plan of any physical meeting. But yes, this is a good platform. And once again, on behalf of IERA, I would like to thank all of you. Particularly, I would like to mention Sanjay here because I am listening him and seeing him first time here live. I've never seen him speaking in the conference. So that is another wonderful experience. So we have very good people now coming in and doing the job. So great. So once again, thank you all of you. See you soon.
Thank you.
See you soon.
you.
Yeah, thank you for, yeah.